And I have rules around crying with patients. I don't think you should. If you're crying more than the patient, you make the interaction about you rather than them. Anyway, sometimes you can't really control it. Hey guys, this week I wanted to discuss a case I've been involved with over the past 2 weeks. And it's a case that kind of touches on consent, capacity, body sovereignty, and the right to die. Because by now, this patient has died. So Mrs. K was a 48-year-old woman who 5 months ago was fully functional. She was playing golf and was a bus driver. One day when she was playing golf, she felt a strange feeling in her hands. She started becoming a bit more clumsy and eventually had trouble walking, went to the doctors and was admitted to hospital. Initially, they thought it was something called a Guillain-Barré syndrome, which is when your immune system starts to attack its own nerves and you start to become paralyzed. This usually happens after an infection, but actually it turned out that she had a type of lung cancer that was triggering a different kind of autoimmune attack on her nerves. And the consequence was pretty similar. But essentially the nerves that supplied the muscles of her body were all dying, which results in a flaccid paralysis where she can hardly move. Sometimes she could twitch, but she couldn't move. And it started to affect her diaphragm, and so she actually had to get a tracheostomy and she was intubated. Now, she eventually became really frustrated and the team was wondering whether she was depressed, which is why my psychiatry team was asked to come and review her to, work her up for depression. It turned out that it was all really circumstantial. The way that we communicated, by the way, was because she could still control half of her face and the muscles around her mouth, so she could mouth words. But to add to her frustration, it was only the speech pathologist that was able to decipher her mouth, because the way that she was mouth words, for some reason, it was just really hard to kind of understand what she was saying. So this is a kind of like a locked-in syndrome, but you can still communicate a little bit. Anyway, when we reviewed her, it was apparent that her frustrations were circumstantial to her environment and her, horrible predicament. And actually, she was saying that often when she would not consent to things, she would still get repositioned or suctioned or have mouth care and stuff when she wanted to be left alone or sleep. Now, the nursing staff would refer to these activities as non-negotiables. That really raised a red flag in my mind because based on our discussions with Mrs. K, she actually had capacity to consent. And when you have capacity to consent, that means you have the capacity to refuse treatment. And as long as you understand the consequences of your refusal of treatment, which could be a pneumonia or death, then people have to respect those wishes. And I kind of get it, like in the ICU, normally you're dealing with sedated or unconscious patients and you're acting in a duty of care ethical framework. Now, duty of care ethical framework means that you do not need to get consent if you're doing something that is in the best interests of the patient. And the classic example of a duty of care case is a Jehovah's Witness who's unconscious and bleeding out, and you need to decide whether to give them a blood product or not to replace their lost blood. And the answer is you can give them blood product against their consent if it saves their life. But this is different. This is a patient who's been in the ICU now for 3 or 4 months and has capacity to interact and give informed consent about different procedures or activities. So one of the things that I brought up to the nursing staff and my psychiatrist that I was working with actually agreed with was essentially that everyone really had to stop using the term non-negotiables for not only ethical reasons, but legal reasons too. There's no such thing as a non-negotiable if you have capacity to consent. And you don't want to not try to do the best thing by the patient, but if the psychiatry team have done a capacity assessment and the person is, aware of the consequences, then you have a duty of care to actually respect the patient's wishes, even if you don't agree with them. When we talked with Mrs. K a bit about why she was feeling so frustrated and why these procedures were annoying her, it was essentially around her body sovereignty being, abused. Her body was everyone else's but her own. She couldn't move, she couldn't scratch an itch. Everyone else was moving it for her. And sometimes they were moving it against her will, which in my view is a form of assault, and I didn't want to kind of broach that subject with the nursing staff. If someone doesn't want to be touched, don't touch them. As long as they understand the consequences of not being touched, I guess. It's a hard one. It's nuanced. And also, just for the record, guys, I'm not an ethicist or trying to be a self-proclaimed ethical expert or anything. I'm just trying to talk about a case that came up in my life that I think is worth discussing. That's it. Anyway, the way that the case ended was sad, and I was in an MDT, so an MDT, multidisciplinary team meeting, and there was the neurologist, the oncologist, all the allied health representatives, social worker, palliative care, nursing staff, and then me. So the psychiatry registrar had a call and had to leave the meeting, and it was just me kind of representing the psychiatry things. And so the oncologist kind of said, we think that there's futility of continuing chemotherapy or radiotherapy. The neurologist said the nerve damage is permanent. They agreed that ongoing care is futile. The ICU consultant accepted the consensus. And then they kind of looked at the ethicist and said, since there is consensus among the medical care teams that treatment is futile, we accept to go towards an end-of-life care pathway, which is palliative care and death, if the psychiatrists deem the patient to have capacity. So everyone looked to me, like a room of 16 big medical bosses all looked at me, and I just kind of said, so I'm the psychiatry student and I can't formally comment on capacity on behalf of the psychiatry team, but I can call the consultant to come and do a formal capacity assessment before making this decision. And that's what I did. And it was just a bit of an intense moment for an alone medical student. But anyway, I'm glad I didn't say anything too silly. I called the consultant over and we went and talked to the patient one last time. And she was just saying, I want to be put to sleep. I want to be put to sleep. Who do I talk to? And that's it's like, imagine how long she's just been struggling for to kind of get to the point where she just wanted to die. And she didn't even want to say goodbye to her family. She was just sick of it. She was just like, I want to be put to sleep right now. And this is all being translated through the speech pathologist who wiped her daily schedule just to be her interpreter for the day, which is such an amazing thing of that speech pathologist to do. And it's just a really sad moment to be there when she's found, she's been struggling for 3 months, and the moment she's finding out that the treatment is futile and there's no more hope, that's it for hope. It's death now. And she was pretty accepting of that. The speech pathologist who was interpreting started to cry, and I started to cry too. And I have rules around crying with patients. I don't think you should. And I certainly think you should never be more emotional than the patient, because the nature of attention is, if you're in a room of people, you will draw your attention to the one who's most emotional. And so if you're crying more than the patient, you make the interaction about you rather than them. And it's not about you, it's about them, and you're a caretaker. Anyway, sometimes you can't really control it. Anyway, I went home after that and got a big cuddle from my partner, and my roommate gave me a slice of her cake and a cup of tea. So I felt well supported. And Mrs. K was extubated and palliative care sedated her, so she had a peaceful death. And I guess the last thing to mention is how grateful we all should be to live in a place where you can have a good death. Not commenting on Mrs. K's death specifically, but just in general, we're in a society where you can die well. And that's a strange thing to say, and I've said it before, but it's something I'm really passionate about, I guess. You don't have to be alone or struggle or, be anxious. We can control medications to balance the anxiety and pain and get rid of the pain, so you have painless death, but also that you're aware and with your family. But yeah, I obviously made that video of the other patient who was not with their family. I'll put a card in it here. That video was just making a comment about how hard it is during COVID, but yeah, luckily with end-of-life care pathways and palliative care, you're allowed to have your visitors come and visit you before you die. If you die in hospital, Whew, okay, that was a pretty emotional video. Thank you for staying tuned for it all. Let me know what you think about these case reflections and discussions. Big thank you to the 211 subscribers that I've got. If you haven't subscribed and you're considering it, please do it and join our small but growing community. And I'll see you guys in the next video. Bye for now.